And I would love to pass it along to my co-host, Philip Dom, who will be introducing our first speaker.
Hello, everyone, and welcome. I have the great pleasure of introducing our first speaker, Olivia Magwood. Olivia describes herself in her bio as an early career researcher, despite very considerable contributions to the field already. She is a fellow of the Campbell's and Cochrane Equity Methods Group. She's a research associate at the Bruyère Research Institute in Ottawa, Canada, where she's also pursuing her PhD. Her focus, her research interests are in knowledge synthesis, mixed method studies, and in particular, as relevant to this talk, in equity-focused methodological and reporting guidance. She also has an interest in stakeholder engagement and health research. And last not least, I wanted to mention that we had the distinct pleasure of having her join us as a previous scholar at one of the former workshops that Madeline mentioned. So without further ado, we look forward to your presentation, Olivia, and thank you very much for joining us to this interactive webinar.
Thank you so much for having me and for inviting me to present today. I'll just share my screen so we get some slides going. Here we go. Perfect. There we are. So thank you so much, and thank you for remembering me back from 2018 when I did participate as a grade scholarship recipient to attend a workshop. That was great fun. So today I'll be speaking a little bit about a topic that I think is quite relevant to the theme of the World Evidence-Based Healthcare Day, which is equity, stakeholder engagement in the guideline development process. And so just to start off, I have no conflicts of interest related to this presentation, but I would like to highlight the funding that's been received by the Canadian Institutes for Health Research. So they fund the overarching project, as well as the scholarship funding that I have personally received from the province of Ontario and the Covidence Global Scholarship. And so I am here today presenting on behalf of the Muse Consortium. So I'm sure many of you may be aware that there's a growing interest in doing stakeholder engaged research and stakeholder engaged guideline development. And partially this is because we recognize that engaging stakeholders in our work is one of the best ways to help us consider equity or other considerations that we may be otherwise overlooking. And so the Muse Consortium came together in 2015 to develop guidance for stakeholder engagement in research, including in the development of systematic reviews and in health guidelines. Over the past 8 years, we have expanded and we now include over 160 individuals in 30 countries, and we're working on 2 funded projects. One which focuses on engagement in guideline development that I'll be speaking about today, and the other about engagement in evidence synthesis. And so in terms of, guidance for guideline development, what is the aim of the Muse Consortium? Well, we hope to provide non-prescriptive guidance for guideline developers as to who they should involve in the guideline development process, how they might engage them, how they might evaluate them, and what level of engagement you might like to give them. So we have developed a protocol and published this. I've got a screenshot of that here. And then in the background that we haven't yet published, we've got a series of systematic reviews which focus on methods of engagement, barriers, impact, and conflict of interest considerations. We've also done an international survey and a series of interviews asking stakeholders how they want to be engaged in guideline development and how we might do this equitably. And so our group hopes to publish guidance on how to engage 10 different groups of individuals throughout the guideline development process. And we will be producing a stakeholder engagement extension to the Gin McMaster checklist for guideline development. So many of you may have seen this before. The Gin McMaster checklist for guideline development includes 18 topics that a guideline developer can work through to help with their planning or conduct of a guideline initiative. And what we hope to produce and launch next year is an extension to this document, which would include who you might engage at each of these 18 steps. We do this across 10 different groups that are outlined here on the slide and 3 levels of engagement. And we're very excited that we plan to launch this at the Global Evidence Summit in Prague next year. So if this is something that interests you, we hope to see you in Prague next year. But what I'd like to focus most of my time on today is, how can we center equity when we engage stakeholders in guideline development? And what steps can we take as guideline developers to make sure that we're considering equity in our stakeholder engagement process? So the first thing we should think about is, preparing to engage in a way that centers equity. And so it's important to consider, how you plan to center equity in your engagement work, such as having a thorough understanding of equity and its relevance to engagement, and reflecting on your own roles and positions within the engagement process. And what I mean by this is that in order to prepare for equitable engagement, equity considerations need to start from the stage of team formation. So right at the beginning of any guideline development initiative, you need to make sure that the members of your team have equity values as part of their kind of team values and cultures. And this means that, for some people on the team, you may need to embed additional learning around social justice, exclusion, and equitable practices to make sure that everyone on the team has an understanding of these concepts. So you should consider participating in an equity, diversity, and inclusion training activity. And an example of this could be the SPORE Evidence Alliance's reflective EDI exercise. The goal here is to identify our own positionality and to understand how that might play out in our engagement activities and in our guideline initiative. So when planning your engagement work, you can center equity by carefully considering who and why you want to engage them. You should build an understanding of the communities you want to engage and set some engagement goals. So within the Muse Consortium, we identify 10 different groups of stakeholders that guideline developers might want to consider engaging in guideline development initiatives. Some of these are likely very familiar and common in guideline projects, such as engaging providers of care or healthcare practitioners and patients and caregivers. However, the Muse Consortium is trying to, encourage folks to consider a broader range of stakeholders, such as policymakers who might be setting health policy, the program managers who ensure that these health programs are being overseen and implemented appropriately, product makers, members of the public, payers of the health services. Our goal here is really to get you thinking beyond the typical groups that you might engage more regularly, and to consider whether or not any of these 10 might also be appropriate for your guideline project. Now, I would like to pause here for a minute and kind of reflect on the issues with the term stakeholder, because this is very much an issue of inequity. So you've heard me say stakeholder throughout this presentation, but really, the Muse Consortium is shifting away from the terminology of stakeholder. And partially this is because the term stakeholder actually has its roots in colonialism, where a stakeholder was the person who drove a stake into the land to demarcate the land that they were occupying or stealing from Indigenous people. And where I live in Canada, this is a very contentious term, and we're stepping away from it because the continued use of that term can be seen as very disrespectful of Indigenous people and kind of perpetuating colonialization and re-traumatization. So we are shifting towards other language, and I would encourage you to reflect on whether or not this shift is appropriate for you as well. On the slide, I've included other terms that might be relevant that could be used in place of stakeholder, such as a special interest group, an end user, or a decision maker. Within the Muse Consortium, we are shifting towards partners and collaborators or interest holders, depending on the topic. And so you might hear me say some of these words interchangeably from now on. Now, when we're looking for people to kind of represent some of these partner groups, members of the Muse Consortium have published a list of factors to consider when you're trying to identify them and invite them to work with you. Some of these are considered highly desirable, such as, is this person able and willing to represent a larger group? Do they have the commitment and the time capacity to work on your guideline project? Do they have sufficient communication skills or the financial resources to participate? But you'll see here I've specifically highlighted item number 6, inclusivity, which is equity, diversity, and intersectionality, as this is particularly relevant to today's topic. And so we borrow the Progress Plus acronym to help us think about characteristics that may stratify health opportunities or may be related to health inequities. So the Progress Plus mnemonic refers to place of residence, race, ethnicity, culture or language or ancestry, occupation, gender or sex, religion, education, socioeconomic status, or social capital. And the plus refers to other personal characteristics that could be associated with discrimination, such as age or disability, features of relationships that may lead to health inequities, or time-dependent relationships. So in presenting you with this mnemonic, it does not mean that all of your stakeholders need to kind of check a box and address all of these characteristics, but it's here to help guideline developers reflect and think about whether or not there are certain perspective or certain experiences that could bring value to a guideline initiative. And so once you're equipped with an understanding of who your population is and why you wish to engage with them, you need to consider how to connect with them, how to really engage them. And so this involves establishing trust, ensuring you reach diverse voices, and reducing barriers to their engagement. And you may need to identify individual support and training needs. For example, the group may contain people with varying understanding of the research process or the guideline development process, and you may need to spend additional time capacity building and training before you can begin. And this is where having a dedicated person on your team who can help coordinate and engage with stakeholders is so important to make sure that they feel like they are being meaningfully engaged and that their needs are being met throughout the process. And so, kind of in the spirit of equity, inclusion, and diversity, the research team or the guideline development team should consider including representatives of populations that experience inequities or that might be traditionally excluded from the process that you're going through. However, there are two kind of recruitment considerations that I'd like to highlight. Often, when we are trying to involve stakeholders in guideline development, we go through a purposive selection of these individuals. And this, while it can be very, helpful and pragmatic and efficient, also risks a little bit of identification bias because this means that we will continue to engage well-known stakeholders, so people who are typically already engaged in the process. And this might exclude minorities and create a bit of an echo chamber. Another popular approach to engaging stakeholders is snowballing, where one stakeholder or one person that can put in a recommendation for another person. But this can also lead to an identification bias or a network bias, which can further compound the risks of ignoring minorities or ignoring people who are traditionally excluded. And so my recommendation to folks who are trying to engage with new stakeholders or people who they may not have engaged with before is to, test and trial new ways of working in collaboration with external groups, whether or not this is an NGO or a patient partner group, and continually reflect on what works and what could be improved. At the end of the day, no stakeholder engagement initiative is going to be perfect. There will always be, barriers and challenges that are encountered, and these should all be taken as, opportunities for us to learn from our engagement work and to improve that in the future. And so demonstrating an ongoing commitment to equity-centered principles throughout the engagement process requires a lot of self-reflection. You need to make sure that your participants are feeling safe, respected, and valued, and simultaneously address power imbalances that may arise along the way. And after you have kind of completed any engagement activity, further work needs to be done to uphold the principles of equity. So this means, following up with the individuals who you've engaged with, acting on their input, and committing to learning and improving from your ongoing engagement work. There are a small number of tools that are available to help people kind of evaluate or self-reflect on their own engagement work. I've included 2 of these scales here on the slide. The first is peers, and the second is the public and patient evaluation tool. Both of these ask that you kind of evaluate, whether or not the stakeholder or the person that you've engaged feels like they have been meaningfully engaged through the process, and whether or not there are things that could have been done to improve it. So I highly encourage anybody who wants to do stakeholder engagement in their guideline initiative to also plan in advance and think about evaluating it, making sure that you've embedded processes along the way that will allow you to learn from the experience and improve it later on so that you can continue to center equity in all of your work. And so if this was of interest to you and you think you might like to get involved with the Muse Consortium, we do send out a regular newsletter that you can sign up for. You can contact our coordinator, who is Jennifer Petkovich, or you can follow us on X, formerly known as Twitter, to stay kind of involved with us and to learn about opportunities to become engaged with the Muse Consortium and help us develop some of this work. And with that, I will end here, and I'm happy to take any questions or possibly pass it off to Elie for more great stakeholder engagement discussions.
Thank you very much, Olivia, also for staying on time. That was a great talk, great introduction to the topic. I do have a question. On one of your slides, I saw that the product makers are listed as one of the interest groups. I think historically, the pharmaceutical industry and device makers is that group that we're desperately trying to keep out because we worry that they're deeply conflicted. So I was wondering whether you could expand on their inclusion as an interest group.
That's an excellent question, Philip, and something that our group has spoken about quite a lot. And I'm sure Elie will have more to talk about when he brings up the concept of conflict of interest. But I hear you. A lot of people are very concerned about, how can we involve a product maker or a member of industry? Should they really be at the table at all? Many people prefer to keep them at arm's length. And so we've identified them as a stakeholder because we agree that they have a vested interest in the process, that they have some kind of knowledge that they want to share with the group, with a guideline development group. But what we have kind of decided as a Muse Consortium is to not allow them to have decision-making ability when they come to the table. So we can go to them for advice or feedback, ask them, for example, about the findings of their trials or effectiveness evidence, but to keep them at arm's length away from the decision-making table. And it will be up to each group to decide how they identify the conflicts of interest related to that group and how they manage them. And I think I'll stop there to allow Elie to, present a little bit on that topic afterwards. But Hassan, I see your hand is up if you have a question.
Yeah, so one of the concerns always we've had with public and patient engagement is the tokenistic engagement. So I wonder if you have some examples that you can summarize perhaps in a paper or in a catalog that were not tokenistic. So maybe like 10 examples where the patient and public engagement has actually made a difference, either in the recommendation on a guideline level or in the systematic review on a synthesis level. You don't need to tell me these examples now, but I'm saying it will be nice to have them cataloged so that people learn from them.
Yes, that's a great point. We have begun, looking at examples, but due to, I guess, very inconsistent reporting, it's very difficult to identify a good example without actually speaking to somebody on the guideline development team, asking them, what went on in the background and how did you truly work with these people? One of our reviews that we aim to publish next year will be focused on impact. So whether or not engaging folks at a particular step of the guideline development process had an impact on the recommendations or the topic selection. So keep your eyes open for that, because I'm hoping that that review has quite a few other examples that we can draw from.
Good. So we'll please feel free to also post questions in the chat if you prefer, if you don't want to speak up, and we'll take questions to both talks towards the end after Elie's talk. My great pleasure to introduce another very distinguished individual, Elie Akl. Elie is a tenured professor at the American University Beirut, where he's also the Associate Dean of Clinical Research. He leads the Division of Internal Medicine. He leads the grade network there, and he also leads a group that has the wonderful acronym of SPARC, which stands for the Center for Systematic Reviews of Health Policy and Systems Research. He has published very extensively, over 500 publications, most notably some of the very early grade guidance he contributed to. He's also a co-author of some of the PRISMA checklists, and it's just fantastic to have him here. So Elie, without further ado, you have the floor.
Thank you, Philip, and hi to everyone. Unfortunately, we don't have a great network. We simply have a great center. That's our ambition. But also, I'm very happy to be part of this series of webinars. I think this is a great initiative. And I'm looking forward to sharing some of the thoughts with you. So I'm going to start by sharing my screen. If you could just let me know whether you could see. Yeah.
Looks great.
Okay. So, Olivia, thank you. Thanks for addressing the issue of equity, but also in doing so, providing some of the background to the Muse project. So I'm going to talk about the conflicts of interest and stakeholders in guideline development. So these are my declaration of interest. My main intellectual of interest is related to the subject I'm discussing today. And there's obviously the funding by CIHR. I would like to acknowledge all the members of the Muse project group, really a distinguished group of fun people to work with. And also Ms. Joanne Fabsa, who's been a very active member of the group and who helped with designing the work on the COI project. So just very brief reminder about Muse. The aim is to develop guidance about how to identify, engage, and involve stakeholders in guideline development. And one of the aspects that was embedded early on in the project is what are the conflicts of interest issues that arise when engaging stakeholders in guideline development. So this is the part that our great center was involved in. And as part of the work, we conducted a systematic review on that topic.
Elie, can I just interrupt you for a second? The slides are not, there's a little bit of trouble on my end with the slides, seeing the slides. Are others having trouble too?
Yes.
Then maybe, yeah.
Okay, should I stop sharing?
Well, I think it just might be a bandwidth or an internet issue. Yeah, maybe try it again.
Okay.
If it's just an internet issue, then okay, looks fine right now.
Yes, this view will probably be better.
Okay. Yeah, I think it was the view. Thanks, Tamara.
Okay, great.
Okay, so we conducted a systematic review on the topic, not published yet, but I'll share with you some of the findings that we found really interesting in relation to conflicts of interest of stakeholders in guideline development. So this is a first quote from a qualitative study. It says, there was a general view that people would bring their own vested interest to the table, influenced by their experiences, their academic or professional specialty, or allegiance to particular products, types of treatment. So the part that was most relevant in this sentence was the part about the experiences. So people would talk about patients bring their experiences to the table. And as I go through this, I would like to invite you to think about some of those issues and how you've dealt with them in your own guideline development projects. This is a second quote. A main challenge with consumer involvement occurs when the representative has a visceral, that's a strong term, personal experience with the disease or an advocacy role that interferes with the ability to examine the evidence and recommendations dispassionately. And the third one, this also makes patient experiences that are inherently embodied and quote unquote interested problematic in the epistemic setting of a guideline development group. Just to reflect with you on this, which one of these you find the most interesting and why? Or let's say the most problematic.
This is Hassan. I think the advocacy role is very problematic to me because usually that is funded through specific channels.
Yes, true. So that could be problematic from the guideline perspective. Yes, definitely. What we were kind of uneasy with, a bit uncomfortable with reflecting in our work is the third one, which says that the experiences of patients are interested, meaning they're trying to say that patients, because of their experience, that are conflicted, and this could be problematic in the setting of a guideline development. And our quick reaction was, why would the patient experiences be a problem? We thought that patient experience should be something that should be somehow reflected. Whatever it is, qualifying them as problematic and as conflict of interest was a bit weird to us. So this is where the whole thing started. And then we started as a group reflecting on this issue of patients' experiences and do they really qualify as conflicts of interest. So in order to reflect more about this, we went back to this definition of conflict of interest, which we had published, I think, a bit earlier. And in this definition, so this is based on a thematic analysis of a large number of definitions. Yes. Okay, so this is based on a large number of definitions of conflict of interest. We went and did a thematic analysis, and this is what we came up with. So a conflict of interest exists when past, current, or expected interest, because some of these can be expected, creates a significant risk of inappropriately influencing an individual judgment, decision, or action when carrying out a specific duty. In this case, when we talk about guideline, the specific duty of the stakeholder is to make a judgment or make decisions when voting or when discussing that serves the best interest of the target of the recommendation or the target group of the recommendation. And then the key issue in this, when reflecting about the experiences of the patients, particularly stakeholders in general, whether those experiences necessarily inappropriately influence that duty. So in this commentary, we further reflected on this issue and about what are the different types of stakeholders. This is a simple schematic to say that the outer line represents the context of the duty, which is development of recommendations serving the interests of the target group, typically the patients. At the center is what the stakeholders' representatives should do, which are making judgment, decisions, or some actions in some cases. And you have here 4 different stakeholder group representatives. And we make the distinction between stakeholder group and the representative. So there's the patients, which is a stakeholder group, and then there's the representative that is representing that group. You could think about the public in the same way. You have the public as the group, but then you have a representative of the public, the frontline clinicians as a group, and the representative, etc. And each of these, as they are making those judgments or decisions, they bring what we classify as 2 types of interest. The first one, we call it non-conflicting interest, We also call it legitimate. And then the conflicting interests. So the conflicting interests are the more classical conflicts of interest I'll come back to. But here we're trying to reflect on the non-conflicting interest. So the conflicting interests, to start with these, there's, and I think, Hassan, you mentioned this, when we did this earlier study, we found that a median of 75% of patient and consumer organizations reported funding from the health industry and serving as a way for those pharmaceuticals and others to influence the research process. So this is a real problem. And these can be classified as individual interest or institution level interest, and different types of ways of classifying them. And people have come up with different ways of dealing with those in a guideline, from declaration to some cases, the verification of the interest, to doing some risk assessment of whether those interests really pose a conflict of interest or not. And if they do, and that's what you see in red, there's a management process. Now, the non-conflicting interest, which we are calling legitimate interest, and we call it legitimate interest based on the definition of a stakeholder. So going back to the Muse definition, a stakeholder group is one that either uses the guideline recommendations to support health and healthcare-related decisions, or is affected by those decisions. And both of these groups, whether they use or affected, have legitimate interests. So, but think more about those who are affected. Those who are affected by those recommendations do have an interest that those recommendations reflect their views and take into account of their experiences. And here we try to list some of the guideline development aspects where the stakeholders have the right to have their views appropriately represented. And here also, I would like to ask you, could you think of some of those aspects that where you think that it's totally legitimate to represent the views of the stakeholders? Again, using the patients as a simple example of a stakeholder. So again, the question, are there any aspects of the experiences of patients that are legitimate to represent in the process and to make sure that they would actually influence the outcome of the development process?
Well, I think there are a couple of ETD domains where we would like to hear from them about particularly the values, right? And then there is the acceptability one, and certainly the equity one.
Yeah, that's perfect, Hassan. Actually, this is how we also thought about it. If you think about the evidence to decision tables, where you have specific factors that influence decision making that are really related to the stakeholders. You've already mentioned the acceptability of an intervention. There are different stakeholders. I want to make sure that they are acceptable to those stakeholders. The value we attach to an outcome, but also what are the priority questions to address? What are the questions that patients are interested in? So all of these are legitimate questions that need to be reflected. And these are, we could qualify them as the interest of the stakeholders. And we call them non-conflicting because they would not inappropriately, if you go back to the definition, it was whether it would inappropriately influence the judgments, decisions, etc. So these ones, we think that are needed to also expected or required to adequately influence those decisions. So the implication of this, one implication is that the individuals representing a stakeholder group, remember we made that distinction, there's the stakeholder group and the individuals. The individuals representing a stakeholder group should align their judgments, decisions, and actions with the non-conflicting interests of their group. And this would be the definition of appropriate representation of that group. We also thought about what are the safeguards for having or considering non-conflicting interests. So first, you have to manage the conflicts of interest. So you have to put this aside, make sure that ideally that person has no conflict of conflicting interest or conflicts of interest before you start addressing their non-conflicting interest. There has to be a balanced representation of different stakeholder groups. So one way to think about it is when you have, talking about post-COVID condition, and you would like to represent patients on your panel, and patients might have totally opposite thoughts, let's say acceptability of a specific intervention. You could think about these as non-conflicting interests, but then you have to make sure that you have a balanced representation of these different views. Also, as a way to balance the representation, you have to have a management of the aggressive advocacy by any of these groups. And the last point is to have adequate education and support to stakeholder representatives. So as it has been suggested, we're not just checking the box by saying we are engaging stakeholders. And this is one of the major challenges of how can we have a meaningful involvement of those stakeholders. So in conclusion, stakeholders representatives bring two types of interest to the guideline development process: the non-conflicting interests of the group they represent and their own conflicts of interest. While conflict of interest must be managed rigorously in different ways, we think that non-conflicting interests need to be adequately represented. So this brings me to the end of my presentation, and thank you for your attention.
Thank you, Elie, for a very thought-provoking presentation about COI. We're happy to entertain some questions. So, Elie, one of the screening guidelines tend to be highly controversial, and representation of patients is, you said we need adequate or appropriate representation or representative representation, to use the word twice. How do you practically go about it? I think one of the things that I see frequently is that we engage, that there's an engagement of individuals that appear to have benefited from screening, whereas those that have potentially been harmed. So how do you do this? Do you include one of each, or what are the practical implications of your work for someone who is, quote unquote, in the trenches trying to build a guideline panel?
Yeah, so I guess that relates to the point of the balanced representation, and how do you balance this based on what factor, experiences, positive, negative, etc. One of the things that I think when the Muse guidance will come out that is really important is the types of engagement. And Olivia already mentioned that. I think we decided that you could engage stakeholders in two ways. One is, we call it the feedback, which is you seek their feedback, you seek their input to reflect those. And the other one is decision-making, where you want them to be part of the decision-making. So one is more engaged than the others, obviously. And one thing we started reflecting on is which stakeholders do you engage them in a decision-making manner versus you engage them in a more of a feedback manner. And the openness might be kind of the key to that. Having an open view about the evidence, about the recommendation, because the principle, the reason why we manage conflicts of interest is because we want the panelists sitting around the table to listen to the evidence, consider the benefits, harms, and other contextual factors, and make an objective, or as objective as possible, decision based on that evidence. So they have to be open-minded. If you have someone who's coming to the panel with a preset conception of what the recommendation should be, that's going to disrupt the dynamics. That's not going to serve the purpose. Again, you want people to be devoid of preconceived notion. So that's why everyone on the panel should have an open mind. And that could apply to the stakeholders. Stakeholders who sit around with the panel around the table should ideally be open-minded. And it doesn't say that you are disregarding those who have strong views. I think it's the opposite. Those who have strong views, we need to understand what are their views. It might be opposite views, but these individuals, we need their feedback, and we reflect their views as part of the assessment or understanding the acceptability, understanding the values, understanding what are the key questions. So they help us with understanding those through their feedback, but they are not part of the decision-making. And unfortunately, we don't have the tool yet, or good tools or valid tools to distinguish between stakeholders who have open views versus who have, fixed views. But I would say this is an important decision point in terms of how to engage them.
Yeah, it seems that the bar to include a stakeholder in the decision-making process should be very high. Right? I mean, because if you think about a methodologist, they're trying to get all this training and certification, and there are so many, 45 great papers so far or whatever. Yeah, I mean, the bar is high.
Yes. High, you're suggesting in terms of the understanding of the methodology and of the process, correct?
Yeah, if they're going to make decisions, the bar should be really high.
Yes. And so the point we're trying to make, they also need to have open view about the recommendation. We say you have option A and B, they should come in with just give me the data. They need to be able to understand the data, process them, and then make the decision accordingly.
Mm-hmm.
And I'm giving the example of the post-COVID condition because, this is a hot topic, and there are guideline development groups being, formed and recommendations being developed. And the question, and, this is very sensitive, it's a politically sensitive issue. And you have groups that you need to involve. You cannot ignore this stakeholder group and that stakeholder group. Otherwise, the uptake, the acceptance, and the implementation of the guideline will not work. So we need to engage them. Again, I think the feedback approach is a leeway where you're engaging them in a way that is informative to your process, but at the same time, that's not going to influence in a negative way the outcome of the process, which are the recommendations.
Thank you, Elie.
So let me answer this question. So we have published this concept of conflicting, non-conflicting, and we haven't heard much feedback about it. I'm just interested whether that distinction makes sense and is, workable in real life guideline development.
Well, what's the tool to determine that? Like, is this just a judgment about making that decision?
Yeah, I guess I think the part about the financial conflict of interest is easy. So, the usual declaration process, have you received money, et cetera, I think that's the easy part. I guess the harder part is what are the non-conflicted or quote unquote legitimate interests. So what are the legitimate interests? We listed few, and we think there's a need for more work to define them. What defines legitimate interest, and how to measure them or how to determine them.
Elie, let me throw you an example. In a urology guideline, there might be in prostate cancer, it might be one treatment management option might be radiation and one might be surgery, right? And you have surgeons and radiation oncologists. Are those intrinsically conflicted? Are they conflicted, or are they not conflicted using your nomenclature?
I think so. I think the first step is to decide whether there are stakeholder groups, and it seems that there are stakeholder groups. Ideally, you would like to find representatives of those stakeholder groups who are open-minded. I think that would be the approach. If I can find a urologist, if I can find a radiologist who are open-minded, I would be happy to include them on the panel. If there is a urologist who has published tons of papers advocating for surgery, then that's someone that should ideally not be on the panel because they're not open-minded. However, I need to understand, how many of the urologists think that surgery is important, because the way you frame the recommendation, the way you frame the implementation, et cetera, the acceptability is important. So same with the radiologist. I would like to recruit a radiologist that is open-minded because he or she would represent an important stakeholder group. And then if there are others, who are not, the way to engage them is through, feedback. And actually, as we do more often now, when we are thinking about the ETD and would like to collect information about acceptability and feasibility, we conduct either surveys or qualitative studies with those stakeholder groups to get their feedback and their views about these factors. And I think this somehow ensures that there is an engagement, because engagement is it's not just about, and again, this is the message of the Muse guidance, it's not just about sitting on the panel and making a decision. Engagement is, getting views, reflecting on acceptability, values, and the other factors.
So, being a surgeon myself, I obviously have interest in this, right? But there's something unique about, the acquisition of surgical skills typically takes years of training, right? And the ideal collaboration has thought about this. It comes up in the context of expertise-based trials, right? When you make people, if there's a new surgical innovation and you make people, you randomize surgeons to either doing the old thing or the new thing that they've invested, huge amounts of time and energy to learn, whether you won't get a biased result at the end. So I think it may be difficult for those individuals, for proceduralists, to broaden this, right, that have put a lot of time and effort into acquiring those skills, and to step back and say, well, I'm going to look at this very neutrally. But I understand what you're trying to do.
Yeah, and maybe that's why the U.S. Preventive Services Task Force, for all of these recommendations on screening and prevention, they have primary care physicians. So maybe implicitly, as far as I know, they are trying to avoid stakeholders who might be too invested in one option or the other.
Yeah.
It seems that you're using the term stakeholder now to include the guideline developers. So like in Philip's example, these are the actual guideline panel, but we're calling them stakeholders as well.
So Olivia, are these, I think we thought about this as Group X. We had not known that Twitter would become X at that point.
Yeah, so the Muse Consortium has had quite a few discussions about how to refer to this guideline developer group, this methodologist group. Temporarily, we're using the term secretariat to kind of refer to, whether it's the US task force or it's WHO or whatever organization is producing the guideline. Typically, they have some set procedures or set ideas or handbooks that tell them how to do a guideline development project. But as soon as you start, bringing other people in, even as part of your GDG or the guideline development group or your panel, the people that you bring into that are stakeholders, right? They're there to make a decision because they represent some kind of end user, some kind of target group. So Elie and I do use the term stakeholder to refer to those people that might be not necessarily around the table that you might involve in feedback or advice, but also those people that are coming together to make decisions.
Yeah, it seems that in all guidelines, almost all the guidelines that you can think of, if you have a treatment A and B, it seems that the GDG or the guideline development group is a group that does A, in a lot of guidelines, right? So like if you think about guidelines of vascular surgery, say something can be done in a surgical approach, and then it can be done by a radiologist, for example. It seems that your guideline panel will consist of people who do one side, so they're conflicted by definition.
Yeah.
Or if they're looking at a drug treatment, drug versus conservative management, say weight loss, for example. So it seems like the guideline panel itself will have this type of orientation to one intervention.
Yeah. Yeah, and actually in our classification of conflicts of interest, one of those is when you make money through a specific service that you provide. You know, this is the conflict of interest. You know, if I make surgeries, or let's, in Philip's example, you know, very specific type of expertise, robotic surgery, and this is how I make my money. You know, this by definition is a conflict of interest.
Wonderful. What a interesting conversation. Thank you so much, Olivia and Elie, for joining us today. If there are no further questions, I think we'll close out here. I have in the chat just dropped the links to worldebhcday.org to learn about more of the events going on all this week. And then to our workshop website, gradeconf.org. Once again, we still have spots available for our fully virtual workshop next week on grade. So we'd be very happy to see you there. Once again, thank you so much to Olivia and Elie. We had a great time and we're very honored to have you join us today.
Thank you. It was a pleasure.
Thanks for having us.
Bye-bye. Thank you.